we want more awareness of the need for cognitive remediation for our loved ones. That's one of the goals of this evening, is to make people, the funders, the people, the decision makers, more aware of this need that we all have here. We're most delighted to have Dr. Chris Bowie come. He was here 2 years ago, and it's so nice that he agreed to come again. I'm so very happy he's here. So he will describe cognitive remediation and answer your questions. And to open the evening, we're really happy to have, again, Councillor Karen Silovitz, who, in my opinion, is like a guardian angel of Home on the Hill. She helps us sometimes when we have challenges. She's always there for us, and she's opened many of our evenings. So we're so happy that she can come back and introduce Dr. Bowie. This Robert Veltheer lecture series is actually funded by a grant from the town of Richmond Hill, a community and cultural grant from the town of Richmond Hill. So it's very appropriate that we have a councillor, particularly Councillor Karen Silovitz, to open the evening.
It's always my true pleasure to be here and to help introduce the evening's lecture and speaker series for the Bob Veltheer speaker series of Home on the Hill. We still hold Bob very close and very dear to our hearts, and of course Maggie and her family. So having this lecture series in Bob's name will always be very special to all of us. So it is once again, my distinct pleasure and honor to introduce tonight's guest speaker, Dr. Christopher Bowie. Excuse me, it is Bowie. Dr. Bowie has a remarkable pedigree. Dr. Bowie is a professor and the director of clinical training in the Department of Psychology and a member of the Psychiatry Department and Center for Neuroscience Studies at Queen's University in Kingston. He is the head consulting psychologist at the Early Psychosis Intervention Program in Kingston and a clinician scientist at the Center for Addiction and Mental Health in Toronto, which we all know as CAMH. His research interests focus on determining the causes and correlates and developing treatments for cognitive deficits in mental disorders such as schizophrenia and mood disorders. He completed his PhD at Hofstra University in New York, training with Drs. Mark Serpa and Philip Harvey. For his PhD work, Chris was awarded the Association for Psychological Sciences Award for top-ranked thesis of the year. After his doctoral internship at the Clinical Neuroscience Center of Pilgrim Psychiatric Center, he did postdoctoral training with Dr. Barbara Kornblatt, earning a Young Investigator Award from the National Alliance for Research in Schizophrenia and Depression, known as NARSAD. Dr. Bowie then took an academic appointment at Mount Sinai School of Medicine and continued to study the functional consequences of cognitive impairment in schizophrenia before moving to Queen's in 2008. He has received 2 additional NARSAD awards to study cognitive remediation in schizophrenia, and in 2011, he received the top-ranked Young Investigator Fellow at the annual Winter Brain Conference. I love that name. He is the author of over 125 peer-reviewed scientific publications and several books and book chapters on cognition in mental illness, including a co-editor of Cognitive Remediation to Improve Functional Outcomes. Currently, he is leading multiple trials of cognitive remediation for severe mental disorders and studying early intervention for mental illness. On behalf of Home on the Hill, Dr. Bowie, we welcome you here this evening and look so forward to the discussion. Everybody, please welcome Dr. Bowie.
Well, good evening, everybody. It's a wonderful introduction, and it's hard to write your own biography, and then when you listen to somebody else read it, it's even more embarrassing. So thank you for making your way through that biography. I'm a clinical psychologist, so my training is in trying to help understand what are the relationships between a person's thinking and emotions and behavior, and how that might help to produce recovery for people with mental illness, or how some other patterns of thinking and behavior might actually sustain disability or make it more challenging. And my interest has always been in studying the conditions that are often understudied and definitely underappreciated when it comes to the healthcare funding system, related to trying to help promote recovery in schizophrenia and related disorders. To that end, my research program for the last 15 years now has focused on trying to discover new ways that we can treat what we call cognitive deficits or cognitive impairments. And speaking to an audience tonight that includes a lot of people with conditions or family members, I'm aware of the language and the effects that that has, and we've thought more recently about thinking problems or cognitive challenges as opposed to cognitive impairment. We've even talked in my field a lot lately about perhaps changing the name from cognitive remediation. After all, when we say the word remediation, it probably doesn't conjure up a lot of positive thoughts for people who might actually benefit from the treatment. So if we think of it not necessarily as cognitive remediation, but optimizing brain health or cognitive health, I think that as we go forward in the next 5 to 10 years, we'll be more inviting as a field for those who might actually seek this intervention. I'm also trained in neuropsychology, which is why I study cognitive impairments in particular, and how I've come to kind of blend those more research-based explorations of what causes cognitive deficits and how can we actually provide treatments. This is a model that looks a little complex. I wanted to put it up first because I hope it gives you a sense of the amount of work that goes into trying to develop an intervention. We're now, in my lab and in my clinical service, providing what is called action-based cognitive remediation. It's what we think of as our flagship treatment. But action-based cognitive remediation, which I'll describe in some detail later, was about 15 years in the making. It took a lot of trial and error for us to, in those early phases, try to do studies in our laboratory or clinics to pinpoint what is the cognitive impairment, what actually causes these impairments or challenges in thinking, and how do the challenges in thinking interact with somebody's emotions, their opportunities to succeed in different areas of life, and how does a cognitive deficit create what we call an ecosystem around the person that might actually make cognitive impairments more challenging for them. And I'll talk a lot more about that later. We then do a lot of studies to try to pilot interventions. So we'll have 10 people in a study, for example, and see, can we actually move this mechanism? I'll show you some work later tonight at the end if I have time that's not about cognitive remediation, but I'm very excited about because it's focused on other barriers to recovery, like internalized stigma. So we have a CBT group that we've developed recently focused on what we call inoculating people in the first episode of psychosis against internalizing that stigma of having a mental disorder. So I'll talk to you a lot tonight about the different interventions that we've had, and following up from my presentation here 2 years ago, try to give you a look at what we've been able to do in just 2 years and hopefully over the next 10 years. This is a wonderful quote from the mid-1800s from one of the earliest psychiatric centers in North America. I cannot too strongly urge the advantage and even the necessity of his being engaged in some regular employment, which shall hold out the promise of some moderate but fair compensation to his industry and prudence. So 1830, we didn't have antipsychotic medications. We didn't have cognitive remediation, of course. We didn't really even have therapies. The modal type of treatment was fresh air in what we used to call asylums. But there were people back then who recognized that if you help a person by placing them in an ecosystem where they develop their cognitive skills, where their mind stays active, where, for example, we look for things that are incompatible with symptoms. Some of the work that we do is focused on identifying things that people find pleasurable and making those a go-to when they're experiencing a flare-up of symptoms. What's incompatible with hallucinating? Singing, listening to music, talking to somebody, calling a friend. What's incompatible with ruminating? getting your hands out in front of you and talking yourself through assembling something, or even, as one of my patients loves to do, he has thousands of Lego kits, and he says, whenever I start ruminating, I can't ruminate if I'm talking myself through putting together these complex Lego kits, right? So we're trying to look for alternatives to the symptoms, and sometimes medications work really well for people to help those symptoms. Other times, the symptoms are more resistant to the medications, and we can try to help people by addressing some of these behavioral issues that we talk about. This is Emil Kraepelin, who arguably is one of the first people to really define schizophrenia. And he talked about schizophrenia, if you use the words, this is translated from German, as really a cognitive disorder. Distracted, inattentive, their mind wanders, they lose the connection. So again, no neuropsychological tests back then, no fMRI or PET to look into the window of the brain, but a real recognition that the barrier for a lot of people with schizophrenia to recovery is not necessarily their hallucinations or delusions. Long-term recovery requires restoration of those problems with thinking, like attention and memory, and the executive functions. Kraepelin also talked about some of the, what we call negative symptoms. So the positive symptoms are things like hallucinations and delusions, but just like cognition, the negative symptoms are often the bigger barriers to recovery. We have a term called anhedonia, which is often thought of as not being able to enjoy things, not being able to take pleasure. What we know is that in schizophrenia, if you ask somebody, do you want to go bowling, they might say no because they don't think it'll be pleasurable. That's what we call the anticipation or anticipatory anhedonia. But if their sister says, come on, we're going bowling, and takes them bowling, they like it. Consumatory anhedonia is not something that we see as often in schizophrenia. So some of what we focus on is that, again, changing that ecosystem or that environment around the person. This other very impressive beard is Bloiler, who was Kraepelin's contemporary. And Bloiler had what he called the 1/3 hypothesis. He found that, again, well before antipsychotic medications were available, about 1/3 of people with schizophrenia had a good recovery. About 1/3 had more of a relapsing and remitting illness, and about 1/3 had more of a progressive or deteriorating course. And so we are, in our work, trying to look at how can we identify what types of treatments might work for whom by figuring out what are the patterns of cognitive impairments and the roadblocks to recovery. So we have made some progress if we define success in treating schizophrenia as closing down long-stay psychiatric hospitals or minimizing the number of beds. These 3 sites were from about a 15-mile radius in Long Island, New York. In the mid-1970s, there were about 50,000 inpatients at these 3 large psychiatric hospitals. The one on your upper left is Pilgrim Psychiatric Center, where I did my clinical internship in 1999. When I did my clinical internship, the other 2 sites had already closed, and Pilgrim was down to an inpatient census of about 680 people. So the deinstitutionalization movement would be considered a success if measured by closing hospitals and reducing the number of inpatient beds. But many of us know that the deinstitutionalization for some was more of a transinstitutionalization, not living completely independently, but going, for example, to adult homes, or unfortunately prisons, or becoming homeless. So the deinstitutionalization movement looked good on paper when you only had the front page, but as you dig into the details, a lot of people really struggled. And what we found in some of our early studies was when you look at what predicts outcome, many people, if we define outcome as being able to be in remission of their positive symptoms, in other words, they have a first episode of psychosis and they start taking antipsychotic medications, about 90% of people with schizophrenia in their first episode will have a considerable reduction in those symptoms once they're on medication. But when we look at sustaining that remission for 2 years, the number drops to almost 50%. And if we raise the bar for what we consider a treatment success, not from getting rid of symptoms, but achieving recovery, being able to function, that's where you see a lot of people with schizophrenia struggling to be able to be symptom-free, return to work, have a social life, and live independently. And so what predicts this? Cognition is in blue, and you can see the overwhelming amount of prediction that cognition or these thinking problems have in how people are able to end up living independently and returning to work. Negative symptoms make some contribution, but when we think of schizophrenia, and when the general population thinks of schizophrenia, often it's the hallucinations and delusions that come to mind, right? Paranoia, hearing voices. When we look at how those symptoms contribute to a person's ability to recover long-term, the figure almost disappears off the graph, because the importance of cognition and negative symptoms is so important in predicting recovery. So what is cognition? When I talk about cognition in this lecture, I'm going to refer to those operations of the mind that help people engage in goal-directed behavior. Things like processing information quickly and efficiently. This is a domain we call processing speed. And in schizophrenia, this is one of the most reliably challenging areas of cognition that we find. Keeping up with a fast-paced conversation, being able to work on a task as quickly as one used to without making mistakes. Attention, of course, is not just being able to pay attention to what somebody is saying, but direct your attention toward a target and ignore distractions. Very challenging for a lot of people with psychotic illness. Being able to shift your attention to something relevant and then come back to the original task. Another challenge for a lot of people. Memory and learning are quite reliably challenging for a lot of people with schizophrenia as well. And we find, of course, that the executive functions might be the most critical domain of functioning. In some of our work, we've done treatments that explicitly focus on these executive functions. We call them the CEO of the brain. Being able to recognize what is an important thing to focus on, and being able to form a concept and reason your way and problem solve your way through a task. These are those executive functions that are critically important for recovery. This isn't very important, it's just a cartoon of a brain, just meant to illustrate that when we do study cognitive impairments, we are looking at how brain changes might occur as well, and how we might be able to predict what kinds of recovery and cognitive changes do we see if we see changes in brain patterns. But I'm not going to talk a lot about that tonight. Just to put up the three, what we often think of as severe mental illnesses, schizophrenia, bipolar, major depression. If you look at, when I say cognitive impairment, what I'm not talking about is an intellectual disability. I'm not talking about an IQ deficit. Across these three conditions, we don't see that people have an IQ problem, right? It's not a deficit in general intelligence. It's the more specific skills, like I mentioned before, where as you go from major depression to schizophrenia, you see that some domains can be really quite impaired. And by severe and profound, what I'm referring to here is a score that falls at about the 1st to 5th percentile. So if the general population is at the 50th percentile, that would mean when I read them a person at the 50th percentile, a list of 15 words, they will probably remember 7 to 8. A person with schizophrenia is likely to remember about 2 to 3 on the first trial. As we go 5 trials later, the person in the general population is going to have a learning slope where they benefit from repeated information, and the person with schizophrenia is likely to have less of a learning slope. They don't benefit from the repeated trials as well. So that's why you see these, what we call cognitive impairments or cognitive deficits, as being critically important. If you put that in the context of daily life, what does it mean to be able to remember a third of what your coworker is remembering? Or what does it mean to be able to solve a problem in 30 seconds when your coworker does it in 18 seconds? So these impairments aren't categorical. They're not all or nothing. It's not that people with schizophrenia cannot do these things. It's that their performance when they have illness tends to be such that they are underperforming relative to the general population, and that really stands out in the workplace, in academia, in social situations, in taking care of the household, and trying to find ways to recreate. So these are really reliable impairments that we see. There are some who argue that schizophrenia is a cognitive disorder. It's defined by cognitive impairments. That disconnection in thinking leads to some of the symptoms that we see. But the other reason we study cognition is because people who come in to see us with schizophrenia and major depression talk about cognition as being something critically important for why they're not able to do what they'd like to do. It's like my brain is stuck in mud. I can't think enough. I can't make decisions. I can't follow conversations. Everyone else at work seems to like change. I lose sleep over it. So just in that one anecdote, we have processing speed, we have decision-making and executive function, following conversations, attention. Everyone else seems to like change. Another executive function, being able to shift when something in your environment changes. What is it, if anybody can volunteer, that you hear when your loved one or yourself, when you experience a challenge with cognition? How does it manifest in different types of life? Some of the symptoms that we see and everyday behaviors are also quite clearly linked to some of the cognitive domains that we study. So being slower to finish tasks at work or in school. You mentioned difficulty following a conversation. The executive functions, things like prioritizing and planning. When we do our cognitive remediation work, it's a lot of helping people remember what's it like to use a calendar. How can you use your smartphone or a diary to help you in your planning? And it's surprising, when you go 6 months without using one of those things, whether it's a diary or a smartphone, it's tough to get back into it. So some of what we look at is not, can people do it or not do it? We look at an actual atrophy. Just like you might find atrophy in muscles for not moving, you might find atrophy in social skills and everyday functioning if you don't do them over long periods of time. So these are some of the cognitive domains that we focus the most on, trying to boost people's attention and memory, their ability to think more quickly and efficiently, and to be able to make decisions, understand things when they change around them, and hold things on in their memory for long term. Another area that's relatively new in the field is called social cognition. So this is what we call, sometimes people say attention and memory are cold cognition, and this is what we call hot cognition because it's intertwined with emotions and being able to understand the intentions of other people. And we know that in schizophrenia, social functioning is identified as a goal for a lot of people, but a real challenge for them. So they have a hard time returning to work or making or keeping friends. I won't spend a lot of time on this. This is just the types of social cognition that we think about. One of the more important ones is what we call theory of mind. Have people heard of this? So theory of mind is the ability to be able to understand what's the meaning of what somebody is saying, what might be their intentions, what is the emotion that they're experiencing right now, what beliefs do they have, to form a theory about somebody else's way of thinking, a theory of their mind. It's a very common deficit in autism spectrum disorders, and we often see it in schizophrenia spectrum conditions as well, that people have a hard time recognizing when somebody makes this micro-expression. That was more of a macro expression, so just so you could see it, but there are very subtle expressions that are confusion, they're not anger. And so if you have a difficult time with some of these social perception abilities, you're going to form impressions of what somebody's intention is, because that look of confusion, because you might have said something, as Kathy was saying, that doesn't make as much sense as you wanted it to, if that's interpreted as anger, then that might lead to paranoia, which might lead to social avoidance, which might increase cognitive deficits. So we're starting to look at social cognition as another really important feature when we try to develop interventions for improving everyday outcomes. I'm trying not to be too academic today, but I'm so excited about some of the work that my students have done recently that I can't help it. So bear with me as I get my professor face on for a moment. This is a study that my recent graduate just did. He's at CAMH now doing some CBT for psychosis and cognitive remediation for psychosis. And he took a task that is called the interpersonal perception task. In a short video clip, typically 30 to 45 seconds, can you identify who these people are and how they're related to each other? Can you identify what the person might say next, given a choice of 2 or 3 options? So they watch a video, and the question here is, who is the child of these 2 adults? And you have to infer based on posture, position on the couch, the way they're talking to each other. Only the little boy, only the little girl, neither the boy nor the girl. Right? And this is a challenging task. People without mental disorders really struggle with a lot of these tasks. So there might be 40 questions, and the general population, you're going to get about 22 of them right. So it's not like these are simple tasks. It takes a lot of concentration. In fact, it takes a lot of those other cognitive skills to be able to focus on and pay attention to these. So we gave this task in a modified way, where we asked people in the early stages of psychosis we stopped the video at 3 different time points, and we asked them, at these 3 time points, which one of these answers do you think is correct? Only the girl, only the boy, or neither? And then we said, how confident are you in your answer? Now, one of the things that we're interested in when it comes to social cognition is a phenomenon that we refer to as jumping to conclusions. One of the reasons why a lot of people with schizophrenia have delusions about the world, right? Challenges in being able to make sense of the world, or illogical or unrealistic thoughts about the world, is that there's a jumping to conclusions. And what causes this? So we know that a neurotransmitter called dopamine is over-released in an area of the brain called the striatum. This is critical for salience, what we consider to be reward, and salience, meaning this looks like it should be important right now. So if you get a massive surge of dopamine in your striatum, things start to become overly salient to you. It's hard to ignore things that you would normally ignore. So you might, for example, look around the room, and things that are easy to ignore have so much meaning that you start to impose meaning on things that don't actually have any relevance. So for example, what does the arc of the green and white mean there? How do I interpret that? Should I make sense of that pattern in some way? What about the red light on one camera but not a red light on the other camera? Is there something suspicious about that? So if I can't ignore those things because I have all this dopamine release in the part of my brain that says, pay attention, this is really important, it's normal to form delusions if you have that happening in the brain. Right? Your brain is saying, pay attention, and you're going to impose meaning on that. Humans want to make sense of the world. So it becomes hard to ignore that. We wanted to know, in a social environment like this, are people with psychosis overly confident in thinking they know that their answer is correct? In other words, do they jump to conclusions? And do they say, I don't need any more information, I already know the answer to this? Well, most of the social situations I'm in, we stop the camera for a minute with my wife, I need to know when I'm wrong, and I need to be able to update my way of thinking about the world. Okay, resume play. So it's a healthy adaptive behavior to be able to say, I could be wrong right now. In schizophrenia, the jumping to conclusions, because of that striatal dopamine release, makes it really hard to shift your view of what might make sense in the world. And that's what we found. I know this becomes a little bit messy. What we found is that compared to a similar age group, this is about 16 to 30 in our early psychosis program, and then people from the community without mental illness, people with psychosis had less of an increase in their accuracy as they were given more information. You see that flat orange line there. So each time they were asked something, they didn't get more accurate. They also, if you look at the second box, had higher confidence early on that wasn't developed until the general population got more of that information, right? So they're maybe overly confident too early, and then early on they say, I don't need that much more information, and so they settle on a conclusion. But in real life, you have to update, right? You have to be able to say, oh, I was wrong. I guess this person's intentions were different. So we need to make sure that we're focusing on these social aspects of cognition in our treatments, and this is a relatively new area for us. Motivation is another critical thing that we're looking at when it comes to not just helping people get through our therapy, but getting into our therapy in the first place. One of the challenges that I and my colleagues in research know, and as a clinician, I know this because when I try to export anything that we're doing in our laboratory to a clinic, to a broader community, you run into a whole host of issues in trying to get people excited to be in your program of research or clinic, right? So again, who wants to go do cognitive remediation? Who wants to do a group therapy? Who wants to spend 2 hours twice a week with us? Like, it's a big ask to get people into these treatments. And so we're focusing on a lot of these motivational aspects as well. And so the other study that we did is we wanted to know if the motivation to perform on social cognitive tasks was adjusted, could we actually help people do better? This is important because what we don't know, especially in the early stages of psychosis, is it a lack of ability to recognize people's emotions, or is it a lack of caring about understanding other people's emotions? So what we did was randomize people to give them a loonie every time they got a correct response on a social cognitive task. Now, what did that do? That normalized performance in early psychosis. When you look at the typical administration of this task, this is a deficit that it's about the first percentile of functioning. But the people who got a loony for every correct response performed almost at the same level as the general population. What does this say to me? It says that in early phases of illness, it might not be that people have inability to understand others. It might be that they're not motivated to understand others. I was sharing this work with a colleague of mine in Galway, Ireland, and he said it could also be they're avoiding understanding others because looking at people and trying to understand them is aversive. If you're paranoid, it's aversive to have to look at and understand other people. So what might happen over time? Maybe we'll see that this social amotivation, this difficulty in being motivated to be in social environments, that's going to lead to, again, this ecosystem where you have fewer contacts in your life. If you have fewer contacts in your life, you're not going to hone those social skills that we need to or hang on to them, right? That very cruel age of onset of major mental illnesses in those late teen and early adult years means that as you are supposed to be developing and refining all of these social skills, they get interrupted and people get off track. So it might be that the actual deficit comes later because there's lack of engagement with an environment that actually challenges people to recognize others. So we're starting to look at social cognition as an important variable as well. I want to try to make it clear that when I talk about cognitive deficits, these are not things that are caused by medicine. We see deficits before the onset of schizophrenia. I've been part of a research group that looked at people who are at high risk for developing psychosis, and those cognitive impairments are there before the first episode of psychosis, and they're also not caused by the symptoms. So people don't have attention deficits because of their hallucinations. When the hallucinations go away, the problems with attention tend to persist for most people. I've already mentioned jumping to conclusions, and I would skip over this except it's a fun game to play to try to show you how this might manifest. This is a task that we use in jumping to conclusions where I would say focus on these two jars. One jar, A, has 60% red marbles and 40% blue marbles. Jar B has 60% blue marbles and 40% red marbles. Okay, jar B for blue, B blue. Okay, so then we give a test and we say, one at a time we put a bead in the jar and we say, how confident are you that you know which jar this is? Right? Which jar do you think it is? What about now? And so we're asking people, how confident are you? Which jar do you think it is? Are you going to change your mind? And maybe now people say, okay, I'm 20% confident that it's the blue jar. Oh, 25, 15%. Back up to 25%, right? So you can look at this jumping to conclusions. And what we see is people with schizophrenia compared to the general population, there is overlap, of course. Really important, again, to just stress that we're not talking about an inability to do something when we talk about impairment. What we see is that people with psychosis tend to reach that conclusion faster and have more confidence in it. And that makes it challenging to adjust your beliefs later on. So one of the really important things that we try to do in our treatment and that I recommend to family members is what we call catch it, check it, change it. Can you catch when your thoughts are too confident and you're forming a belief too fast? Can you change it? Can you modify it in some way? Right, so we're trying to make sure that people, when they are recognizing that I think I know something, it's good to say I could be wrong. There's nothing wrong about saying I could be wrong, right? That this is one important thing that we do in CBT and in the work that I do in psychotherapy, right? Catch it, check it, change it. So catch yourself rushing to those thoughts and jumping to conclusions. Check it. Test this belief. What might be an alternative belief to this? What if I thought about it from a different way? And we do this in a very non-confrontational way. We're trying to allow people to develop that skill to check their own thoughts, right? And then change it. Give yourself the opportunity to be flexible and say, I could be right, but it could be this as well. I had a patient I was working with. I worked with him for actually a couple of years, and he had a great saying where he said, I came up with a new thing you can use in your therapy. And he said, you know, like in a canoe, you might have two people and you have two oars. whenever I say or, I try to think of somebody, a third person on a canoe. Because whenever you say or, you're presenting yourself with only two options. So I see a canoe with 3 oars. I never want to have a canoe with 2 oars. And I said, well, what about the stability? And he goes, no, it's abstract. You got to follow me here. So, but he had this great way of catching himself. And he said, whenever I say or, so when he said to himself, I better get this job or I'm going to be homeless. He said, or I could talk to my parents, or I could ask a friend, right? So what is the third or? What's the fourth or that you can use in trying to catch yourself jumping to conclusions? I won't test your cognition all night, I promise, but one of the advantages of having the microphone is I get to do that. This is a test, not of memory per se, but of what we call source memory. And in this test, we want to know not just do people remember things, but do they remember the origin or the source of that information? So what I'm going to do is show some words, and you as the audience can read the words that you see out loud, and I'll read some other words. I'm not going to tell you anything else for now. Try to remember all of them. With enthusiasm. Pigeon. Bank. Rabbit. Pearl. Bicycle. Monkey. Okay. Now, it's not a memory test per se, it's a test of whether you said it or I said it. And the good news is you don't have to say these out loud. You can just pretend that you got them all correct. In the real test, it's about 80 items long, and it's not only did you say it or did I say it, but was the word not actually there. And so what we're looking at here is source memory, right? And again, what we see is in the general population, we find that in the general population, people remember more the source of the item more than people with schizophrenia as a group. So what we're doing here is looking at a model, a cognitive model for hallucinations. And what we're testing is, do people with hallucinations, not just people with schizophrenia, but with people with active hallucinations, have more of a difficulty identifying the source of information? And the reason we're doing this is because hallucinations in reality feel like the voices in my head, but they're actually somebody's own belief that is experienced as external to them. So when people make a large number of errors in this task where they say they said the word, but actually I said the word, that's highly associated with hallucinations. And we actually found in one study, people who did not yet have a psychotic episode, but were at risk for one, the more errors they made on that task where they thought their own thoughts were presented by somebody else, the more likely it was 2 years later that they had schizophrenia or that they had higher rates of hallucinations. So we're looking at these cognitive models to try to understand symptoms, not symptoms to try to explain away these problems with attention and memory. There's not a lot of evidence for positive effects of medications on cognition in schizophrenia. There have been a lot of trials, and the pharmaceutical industry has spent a lot of money in the pipeline trying to develop cognitive enhancing interventions, but there aren't that many that have been found, and those that are found aren't very well replicated. There is quite considerable evidence that medications that have high anticholinergic affinity, so the cholinergic system in the brain is critical for learning and memory. You can see some compounding problems with cognition. So a lot of people are on these sedatives to help control the akathisia and movement problems, and those can make the cognitive impairments a little bit worse. They also can suppress response to cognitive remediation. Now, some people have to take them because the akathisia and other symptoms need to be addressed, but it is a challenge for us to be able to try to promote cognitive health when people are on medications that affect the cholinergic system in the brain. This is an advertisement from a commercial company that uses brain training, and you've probably seen these. And there's lots of people trying brain training. There are a lot of people wondering, can I get a subscription to this product and help people? Well, when we work with people with psychosis and depression, this is not how they respond to tasks that ask them to think really hard and give them a lot of feedback saying, wrong, wrong, try again, wrong, right? This posture of leaning forward and smiling. What we hear from people is the critical role that our therapists have and helping people understand that the impression they have of their own cognitive abilities is valuable, that it has meaning to them, and we recognize that. And when that it doesn't feel good to see wrong or to not succeed. But this is a training environment. And in here, just like my basketball coach used to make us run plays that didn't work in the game, but we wouldn't know they wouldn't work in the game until we knew they wouldn't work in practice. Right? This is the environment where we can test out what are our cognitive strengths, what are the strategies that help us understand how to use our cognitive strengths, what are our cognitive limitations, and what are the strategies to help us work around those cognitive limitations. And that's very hard for people to do on their own. That's why this is a therapy. And it's a therapy that does work. We see that people, when they receive cognitive remediation, this results in schizophrenia, that it actually does change brain function. There was a study of 2-year follow-up, 2 years after people received cognitive remediation, and they showed that the size of the hippocampus, the brain structure critically responsible for learning and memory, was larger in people who got cognitive remediation, people with schizophrenia who got cognitive remediation, than people who didn't. Right? So you see actual changes in brain structure, in brain connectivity, and in the electrical activity of the brain. You also see serum BDNF. BDNF is brain-derived neurotrophic factor. It's a chemical that we can study that's associated with what we call neuroplasticity. So you need these to be able to form new connections in the brain, for the brain to be strengthened by forming new connections. Right? Think of an internet connection with an old Ethernet cable, or the dial-up, I won't make the sound that you used to have. And if you think about the integrity of that signal, what we're looking for in cognitive remediation is cleaning up and strengthening those signals from different brain regions and within different brain regions, so that thinking can occur more efficiently and more accurately. Okay, so a lot of what we're looking at here are changes in cognition, even reductions in symptoms, and hoping that we go from not just computer training, but actually a therapy that helps people recover. So I'll take you through some of the methods. The first method is what we call cognitive training. So I did say, of course, being in front of a computer on your own does not have very good evidence that it's going to help people recover their functioning abilities. That's unfortunate, but the reality is it can be actually challenging for a lot of people. We did a 2-week study. So this is only 2 weeks of cognitive training, and we found improvements that would be considered statistically and clinically very large for people. They went, for example, from, I mentioned being able to remember 2 or 3 words out of 15 to 6 or 7 out of 15 after 2 weeks of intensive daily treatment with cognitive training. Difficult to see this perhaps, but we also looked at the brain's electrical activity. And there's a signal that we can deduce called theta activity in the frontal cortex. And a lot of theta activity means that working memory is occurring. The person is thinking and able to store things and manipulate them. And you can see in the placebo condition, you see really no change in this front part of the brain. When they receive treatment 2 weeks later, lots of change in that frontal network that is highly associated with those executive functions that I mentioned earlier. But it's not a therapy when they just get this computer task. So this is the effect size, 0, no effect on social functioning or global role functioning when they only get cognitive training. So, controversial idea, but if we want this therapy to work, we need therapists, right? And this is something that, as we talk about funding and dissemination and knowledge exchange, we need to make sure that healthcare providers understand that it's not getting somebody a subscription on their iPad and hoping for the magic of neuroplasticity. It just doesn't happen for a lot of people because they get turned off by it, and it's not associated with recovery of functions. So a lot of what we focus on as well is developing strategies. If I give you a list of a list of numbers and ask you to say them backward after me, right? So remember these words I say, and then think about how you would say them in the reverse order. 7, 5, 1, 9. Okay? What was your strategy on that task?
Saying them backwards before we got to the end.
Yeah. The modal response we get in treatment is, I tried hard, I don't know, I use my memory, right? So a lot of people with the conditions we're working with don't come at these problems by saying, what strategy can I use, and can I modify the strategy if it's not working trial to trial? So a lot of what we do as therapists is help people identify, actually you do have a strategy. I hear in what you're saying when you solve that problem that you are clustering things together in smaller bunches, not trying to remember everything at once. Or you're using rehearsal right after I say them so that it doesn't decay over time. Or if you came to my talk 2 years ago, you're hearing it again. And repetition is one of the most important things we have for remembering things, right? We don't find too much change when we only have strategy monitoring added. That's where we need the third component, which we refer to as bridging. How do we make these new strategies that people are developing and the cognitive gains that they have relevant for their everyday life? And what we used to do is talk about that. So we would do cognitive remediation with the computer for about 20 to 25 minutes, do some strategy development, go back and do 20 more minutes of cognitive training. And then as a group, we would say, now, Joe, you talked about trying to make a new friend at work. How could these strategies help you? That's really hard for a lot of people. And so what we've done is make some changes to how we do this instead of, I'm getting ahead of myself in my slides, but we now don't just talk about it, we actually do it. We mock up the real world. These are the effect sizes on everyday functioning, work, living independently, and recreation. When you do just the drills, just the exercises, you don't see a very large effect, but if you add a therapist, you can increase that effect. If a person gets cognitive rehabilitation and they have a therapist, and they're also in some other skills learning environment, like vocational rehabilitation, social skills training, competitive employment, or school, then we see what are considered statistically to be large effect sizes. So a person has to be, I keep using this word, cognitive ecosystem. If they come in to see us twice a week for 2 hours, there are a heck of a lot of hours throughout the rest of the week where they might not be cognitively engaged and they might actively avoid challenges to brain health. Right? So we want to make sure that we address those. So in spite of these really nice effects that we see on cognition and brain functioning, the story of recovery still has been a challenge. And so we've tried to create new techniques to help people. And that first slide I showed you, we did a lot of experimental studies to try to understand what are these limitations? Why aren't more people getting better when it comes to their functioning? Are people familiar with the notion of duration of untreated psychosis, duration of untreated illness? This is a very popular phenomenon that's been studied in the past 20 years or so, and it's really one of the main reasons why we have such high funding for first episode psychosis, because one of the predictors of long-term recovery is how long is a person experiencing psychosis before they receive treatment. So if their first episode of psychosis is now treated right away, we're hoping that we now get better outcomes. So one of the challenges that we have with correlations is they don't necessarily imply cause. And what we have discovered actually in the last 25 years is that duration of untreated illness is critical for some things, like how many times you're rehospitalized or how well your symptoms respond to medications, but they're not very it's not very highly correlated with recovery when it comes to functioning. And I think that's because we have other things. We know that cognitive impairment starts before the first episode of psychosis. When we do follow-back studies of a person has psychosis at 19, and we look at their academic record, we can see a decline for the 4 to 6 years before that first episode of psychosis. We also see withdrawal and social isolation and challenges in the workplace. And so I coined these terms, which I kind of regretted because they sound funny, dookie and doofy, to go with DUP, duration of untreated psychosis. And I think this is why cognitive remediation, in spite of enhancing cognitive impairments, is not producing functional recovery, because we have these very long periods where it's not that people necessarily can't do things, it could be that they actually miss the opportunity to do them at those critical time periods. So we did all this research to try to look at the barriers. We identified all of these barriers to how people might move from cognitive gains to functional gains. I think this is your last test of the night, so bear with me. This is the fun one. So this is called an NBAC test. This is a very famous test of what we call working memory. Can you hold information online and continue to perform a task while you hold that information online? Right? So when our patients talk about working memory, they don't say working memory or the NBAC. They say, I was scrambling eggs, the phone rang, I answered the phone, the eggs got burned, I hung up the phone, I went over to do the eggs, but the toast burned. So it's that ability to hold on to one thing and manipulate it and then continue to problem solve and do other tasks. So I'm going to give you this test, and you can clap your hands or stomp your feet or make a sarcastic noise, whatever you'd like. If you see the same number appear twice in a row, that means that that number was 1 back. So 7, 5, 5, 1 back from 5 was 5. So that's a target. So if you see the same number twice in a row, just make some noise so I know we're all still awake. It is hard to see people in the back. I don't hear any snoring. But okay, so here's 1 back. Ready? Okay, good job. So not a standardized testing environment, and nobody's judging you, other than the person sitting right next to you, especially if you're married to them. So what we did in this test is not only look at accuracy, but we measured heart rate, we measured skin conductance, this is how much people are sweating, and we asked people to rate how motivated were you on that task, how anxious were you, how frustrated, how well do you think you did. Okay, so we had them do that, and then we did the 2 back. Now, it's not just an attention, are these 2 numbers in a row, but was this number presented 2 numbers ago? 9, 4, 9, yes. 1, 9, yes. 4, no, but 4 was there before, so 4 is a lure. So if you need a washroom break, this might be a good time to do it. So here we go, just to get you experience with the N-back, 2-back test. Okay, so you can see that this is now frontal lobe firing away, right? You can feel that up there. There's a 3-back as well, which now you have to remember 3 items ago. Let's just go through this, and you don't have to make a noise this time, so nobody has to claim it. But you can see, trying to remember 3 numbers ago, really challenging task. So we did this test at the beginning of a cognitive remediation trial. Now these data are with people who had major depressive disorder, but we're looking for the same thing in schizophrenia right now as well. What we found, which is kind of interesting, is you go from 1 back, where we have like 97 and 98% accuracy between depression and a community sample, to 2 back, you see both groups declining, but at the same rate, right? So it's a harder test, so people don't do as well, but in depression, they're actually declining to the same degree as the community controls. When you get to 2 back, 3 back, that's where you see depression, people with depression performing a little bit worse. Now remember that task where I said how motivated were you, how frustrated were you, and how engaged were you? Here's what we see. People with depression, in spite of having the same decline from 1 back to 2 back, have this catastrophic reaction. So people have talked about the catastrophic response to failure. This is a catastrophic response in spite of success, because they did find the task harder, and in fact they did get fewer items correct, but they don't know that they got the same number of items correct as they're supposed to. So their reaction is to disengage from the task, to lose motivation, to feel anxious, heart rate goes up. Now, that's really important. How does cognition interact with cognition? In other words, how do my thinking skills interact with my attributions about my thinking skills? And this is what we're looking at in cognitive remediation. So we developed action-based cognitive remediation to address some of those attitudes and beliefs about cognitive abilities, to do a lot of goal setting that we can embed within the program, and to use a lot of skill training so that the computerized cognitive tasks that we do aren't abstract and irrelevant. We map them directly on to some of the everyday activities that people talk about wanting to restore. So we do that, I already mentioned, with a lot of these new techniques in ABCR that are not found in other cognitive remediation treatments. And this is the reason why, this feedback model that we think of. If we have cognitive problems, even if we do have cognitive problems, a lot of people overestimate their deficits in cognition. They'll perceive everyday tasks to be challenging, and when things are challenging, we lose our self-esteem, we lose our self-efficacy. If we don't believe we can do the task anymore, then we're going to avoid those tasks that don't make us feel good. And what do we know about cognitively understimulating environments? They feed back into cognitive problems and make them worse. Right? So there are studies of animal models where being in a cognitively enriched versus an isolated environment, you actually see atrophy in brain structure and connectivity in isolated environments. So this looks like a very problematic cycle, What we're trying to do in ABCR is use this to say, it's not just here where we have the treatment. The treatment needs to come here, it needs to come up here, we need to think about these, we need to address this, and we need to make sure we change everyday life as well. So it's a full package, it's not just cognitive training. And I think, when we talk about some of the challenges that people have, it's not always because that they have always failed to do something, oftentimes because they missed the opportunity to do something. This is a quote from somebody I was working with doing CBT. It's not that I can't do it, I never had the chance to do it. I don't even know what not to do. Right? So this is a real challenge for a lot of folks. When you talk about skill acquisition, it might not be rehabilitation for a lot of people. It might not be recovering the skills that they lost, because if they became ill at 16, they didn't have the chance to acquire those skills. These aren't data. This is my roommate in undergrad, and he was really fun. You can see that illustrated by the number of romances that he had in this figure on the top. And he worked a lot. He had about 5 different jobs throughout university. He played hockey. I'm getting close to identifying him. He was just fun. He did as much as he could, but he made a lot of mistakes. Right? So he lost a lot of relationships, because when it's appropriate, when you're 17 and 18, you say things about your girlfriend's mom, or you show up late to work, and you figure out what not to do. And I think one of the issues that we face, given that cruel age of onset, but also those pre-morbid early years where a lot of people in that prodromal phase are disengaging from the world, they're disengaging from school. It's not oftentimes that they can't do it, it's they never had the chance to learn how to not do it, right? And so trimming away, being able to understand what not to do is critically important for learning what to do. And that's why in cognitive remediation, we stress the importance of making mistakes in this training environment. We talk a lot about, it's great that you got 40% correct. What were you doing? And let's talk about how a different strategy. In other words, we move that idea of locus of control, what caused this, from I can't do it to my strategy didn't work. And that's one of the real principal things that we work on. What am I doing to solve this problem, and what could I do differently? I have 3 kids. This young man is none of my kids, but looks like a lot of them, because they love Legos. And one of the things they love about Legos is the feedback they get is auditory, the snapping together of pieces. It's tangible because they can build things with their hands and feel it. It's visual because they can create things. It's a lot of things to them. And in cognitive remediation, we need to make sure that people get their hands out in front of them. One of the quotes I had that I loved from ABCR was a patient who said to me, this sounds really silly, but during the computer tasks, I didn't think I was getting better. I thought the computer was making me get better. When you made me do everyday problem-solving tasks, when you put things in front of me, I have my hands out in front of me, and I realize how long it's been since I saw my hands. I sit home like this, watching TV or thinking negative thoughts, and you made me get my hands out in front of me, and that made all the difference, that I could actually see. He said, I know this sounds ridiculous, but I can't change the world if I don't see my hands. And so what we do in cognitive remediation and ABCR is the computer tasks where we have complex challenges to thinking and people have to learn new approaches to strategies and problem solving, but we pair that with activities related to daily life. In this bottom one, we interviewed vocational rehabilitation specialists and employers who were hiring out of our vocational rehabilitation program. And we mocked up workplace situations so that we could find things that are relevant to the workplace. In this one, which looks strange here, we're stressing that social cognition, emotion expression. We have a little mask here. So what happens, this is Dan, one of my former research assistants. If I cover Dan's eyes, how much harder is it for you to understand what emotion he has right now? So the importance of being able to shift your attention to those relevant facial features to understand their emotion. So we mock up the real world, and in one situation we mock up the workplace, so that people don't just talk about how they would use these new strategies. They get up out of their chair, turn around, and engage with a simulated work environment. The strategies are on the board for them, and they start to prune away strategies that aren't working and develop new strategies. So patients say things like, I feel like now you've given me a construction belt where I have tools that are strategies. And I know that if something's not working for me, it might not be that I can't do it. It's because this strategy isn't working, so I need to pull this one out. We have lots of social activities as well. So planning a trip to an amusement park, and you're taking your friend's teenage cousin who wants a really wild experience. So look at this amusement park. Look how much these rides cost. You've got $40 in 2 hours. Find the activities that look like they might be most thrilling for this young man, and find a plan for how you're going to get there and which ones you can do given the amount of money that you have. Think complex thinking and problem solving. So what happens? Well, the good news is that cognition can be moved. I've already told you that. When we look at a T-score, 50 represents the 50th percentile, and 40 represents about the 20th percentile. Okay, so we're seeing here that in either ABCR or more traditional cognitive remediation, we see improvements in cognition that are quite substantial. And we hear people talk about, in ABCR, not just the cognitive performance, but their confidence in their cognition. I never would have tried something so challenging if I didn't have the chance to learn how to approach those challenges. Right? So we at the end of the session, we spend 20 minutes goal setting. What are 3 cognitively challenging activities that you can engage in that might give your brain a good healthy workout in the week? We also measure not just does cognition improve, but does your ability to do things like handle money, schedule appointments, plan a dinner for friends, take transportation, does that improve as well? And here we actually see that ABCR outperforms traditional cognitive remediation. So those role plays and simulations give people a boost. And when we talk about performance here, again, it's the enjoyment, the pleasure in doing them, right? So being able to engage with a task without having to focus so much on the outcome. One of the mantras that we have in ABCR is it's the process, not the product, right? Immerse yourself in training. Don't worry about 80% accurate, 90% accurate. It's the process of giving your brain a good workout. We also had in our ABCR 60% of our patients returning to work 6 months after treatment ended, compared to only about 25% in traditional cognitive remediation. So we're following this up now with a 2-year follow-up study that's about to start to see whether employment is retained. But I do see a couple of people in our community who I know were in ABCR, and one of the lovely things that you get is, in therapy sometimes it's sad because you work with people for 8 to 12 weeks and then you don't know what happens. But if you go to the store where they work every month and they say, tell Michael, who is my student, that I love him and I'm still using the strategies, I still hear him talking about use those strategies, that's a great outcome. So we see that is maintained, at least in that anecdote. So a lot of what we're doing, if you're familiar with CBT, a lot of what we're doing in ABCR is focused on those attributions, the way we think about our self-efficacy and what we might be able to do. We also saw still elevated but lower job stress among the people who were working in ABCR. So not just working, but working and feeling a little bit better about this. This might be my favorite quote from ABCR so far. And in one of the first groups we ran, we had 8 people and 2 dropped out because 1 got married and 1 got a job. And we said, this treatment works too well. People drop out before they finish it because they're getting married and working. The other really important thing is retention. So we get more people sticking with it. And I think that goal setting is really important. They talk about things like being able to put their symptoms in the rearview mirror and focus on what they can actually do next. So let me just quickly mention that we're really expanding this. This is my good friend and colleague in Montreal, Martin Lepage, who is studying social anxiety with CBT and ABCR, and we're finding really nice effects in his study as well in Montreal. At CAMH, we just published this study last month. ABCR outperforms a type of treatment that helps people work around cognitive impairments rather than trying to restore them when it comes to community functioning. And from 2 years ago, I have a little bit more positive news in terms of trying to move cognitive remediation into daily life. Last fall, we trained 35 sites in the Ontario Early Psychosis Network over 3 days, and we're keeping in touch with them with monthly phone calls and an online forum to disseminate and move ABCR into the community at large. So we're now making this a part of the early psychosis network within Ontario. So we have the potential to treat up to 5,000 people a year with cognitive remediation through this initiative. We're also we have sites in Tokyo, New Zealand, Copenhagen, and Ireland. And so we're really trying to make this a part of standard care. The real challenge, of course, is funding for treatment, and how do we make sure that people could be trained to provide the service and provide it in the real world. So some of the initiatives we have are, if you have billable hours for therapy, this should be considered a therapy that is billable. We have, I was telling Kathy, the other thing I'm doing more surreptitiously is I'm just trying to send all of my academic academic children out into the world. So right now I have my students just started at UT Scarborough, one in London, Ontario, another at CAMH, and they're all doing or starting cognitive remediation at those sites as well. So I just want to tell you about some of the other things that we're doing as we shift. We're not shifting away from cognitive remediation, but as we continue to explore. We have a program called Boost. This is a free program that we make freely available to people who are providing mental health care. We have an online forum where we train people and help them implement Boost. This is a peer support assisted program that helps focus on internalized stigma. So we have a manual, it's based on CBT. We just published some initial results showing that it helps reduce internal stigma, it increases self-esteem for people, and we're looking now at doing it throughout the same Ontario network using the telemedicine network where our peer support worker in our lab is going to be able to connect with people. So if you have a healthcare provider who might be interested, let them know about Boost, which is a free internal stigma program. I also wanted to leave you with some resources. There's a program called CogSmart, cogsmart.com, that you could share with clinicians. There's also, I think, it's free to download. The manual for the treatment is free to download. It's a colleague of mine, Elizabeth Twomley, in San Diego, California. So it is a manual to provide treatment. I've had a lot of family members tell me that even though they're downloading a manual as a treatment manual, there's some helpful information in there for understanding cognitive challenges that people have. There's also a free download of a manual that my colleague in New York, Alice Medaglia, developed through collaboration with the New York State Office of Mental Health that provides a handbook for family members and people with psychiatric conditions to help understand cognitive deficits. And then we are launching an accreditation program to try to make sure that people can do cognitive remediation, since its interest is exploding, but people still don't actually have access to it. I'll put this page back up in a second, but I also just want to make sure I say thanks to all my great friends who are doing ABCR now around the world and trying to make sure that we find some more support for it. So I thank you very much for your time. It's really meaningful to me to be able to talk in I guess I'm still talking in an academic way, but to a non-academic audience primarily, and this is one of the more valuable things that I get to do, so I really appreciate your attention and look forward to your questions.